Okay. Good morning, good afternoon, and good evening, wherever you are, wherever you're zooming in from, to have a look at this video. This is part of our communication tape series. And today we're chatting with Deanne Burge, who is a nurse practitioner and works as a residential in-reach nurse across the Wangaratta region and supports aged care facilities across that region. But she's going to tell us a lot more about herself. Good afternoon, Deanne. How are you?
I'm well, very well, thank you. Good afternoon.
Thanks for joining us.
Lovely speaking with you, Rose.
Yes, it's been so long. Yeah, so as part of our communication tape series, we're just doing little short interviews with people who have got something to say in the area of aged care, palliative care, and particularly the communication side of things, because as I keep banging on about, communication is absolutely fundamental to good palliative care. So if you could just start with a bit more expansion on what you do and who you are and how you help how you support the aged care workforce.
Cool. So my name is Deanne Burge, as we have said. I'm an older person's nurse practitioner. I endorsed as a nurse practitioner in 2011, I think it is. Sorry, I have to think about that. My role currently is in residential in-reach, as Rose has said, and what I do is I, along with my team, travel around our region and we visit nursing homes to support staff and to support residents and families with the goal ultimately to keep people out of hospital. So we are a hospital or an admission prevention program. We also provide acute care and everything in between, I think. We are not supposed to replicate what the facility provides or what the GP provides. So we do try to find those gaps in between, and there are many. But also support, and so we can work in tandem, and palliative care, particularly end of life care, can be one area where we can work a bit like a tag team sometimes with the GP to ensure that the facility and the resident and their family can have really frequent and good reviews, so that we're able to ensure that their care and their symptom management is current and fulfilling their requirements.
I think this is a good opportunity just to tout the role of the residential in-reach. I don't know that I certainly wasn't aware of this role until I came to Wangaratta, because working in Mount Beauty, we didn't really have access to a residential in-reach nurse. So I think it's great. Now, how big is your catchment? And if we're talking to all the people in Hume. So how far do you go, and who picks up where you leave off?
Sure. Well, we're in the Central Hume area. There is a new residential in-reach service starting up with Albury-Wodonga, and Shepparton have been going for quite a while. So my catchment currently, and there are a few shifts happening in the near future. So my catchment includes Wangaratta, Benalla, Mansfield, Yarrawonga, Indigo, and Alpine. Now, this does stray into other areas, and particularly up north with Albury-Wodonga coming on board. They will take on some of the facilities that are closer to them and that refer into Albury-Wodonga Health rather than down here to Northeast Health. It also means that we will go further south. So Northeast Health, or we will pick up Violet Town,
right?
Because there are a number of towns or facilities that haven't had access, like Mount Beauty. I mean, and to be fair, officially Mount Beauty did belong to me.
Yes,
but it was a bit too far.
Well, the thing is that we really needed a service like yours because it's attached to a hospital, and so if a resident needed more acute care, we'd just move them into the hospital for the day or for a couple of days or whatever it takes. So,
Yes.
and we had and we still do have RNs who work across both spaces, so the workforce is equally well skilled in acute care and that sort of thing. So that was why I never came across you, because we never really had the need for it.
And that is very much the way it tends to happen. The facilities that are co-located with hospitals, we tend to see a lot less of them and have less referrals. We do still see them sometimes, and I do think we do have a role. But as with any service, it very much does come down to the staff in those facilities knowing about us, what we have to offer, and making a referral.
Yeah, right. So getting back to the topic at hand of communication, what do you see as some of the challenges in your line of work and in your day-to-day role? Where are your biggest challenges around communication? Where do they lie?
With residential care facilities, and it changes, or it's different with each facility. It's very good communication is very dependent on stable staffing, and as to how well we are going to work with someone or a facility, or whether residents have the opportunity for us to provide care, very much depends on the staff knowing about us. And you really do see that in a stable residential care facility, then of course the knowledge stays, and they're able to build on that knowledge, and what services are available to them is utilised much more effectively and much more frequently, really. And I'm not comparing good or bad facilities. I've been working in residential care since 2000 in other roles, but it only takes a little bit of upset and you can lose staff, and staffing and can become unstable. So it happens in a lot of facilities. But you do see them then pick up and to pull things back together, and you'll see the agency no longer be as required, and you'll see more and more permanent staff.
Yeah, and
that makes a big difference to communication and how things are managed.
Yeah, I suppose then it comes back to if the staffing is a little unstable, to try and make sure that processes are in place so that people follow a set pattern, regardless of where they're from, regardless of whether it's their first day or their 50th. If there's an established process in place, then people know what to do. Yeah.
I think we're once the longer we're about, the more established a service we become too. So even if people have worked elsewhere, I would like to think that they've come across residential inreach in any area in Victoria, so that they're aware that service is available in residential care.
Yes, and it sort of highlights the point that communication isn't just about communicating with the resident or their families. It's about how the team communicates with each other and how they interact with outside services such as yours, and that all those things have to be working really well for palliative care to be done in the best way possible.
I think also with residential care, there is very much a team involved, including the resident, the staff caring for them, the family, the GP. So there is a whole lot of people around, and that's you might also say that that's very much the same out in the community as well. But there's many more than just dealing with the patient and dealing with what their requirements are. So there's yes, often multiple parties that need to be contacted.
Yeah. So what have you seen as some of the common sort of pitfalls where communication has fallen down, which resulted in less than ideal outcomes for the resident? Like, where would you sort of say is the most need for improved practices, I suppose, in your experience?
I think when and I'm going to put this say a more clinical word, when goals perhaps aren't known or not clear. You can have difficulty if you've got someone who's deteriorating. They may or may not be able to communicate what they want, and if goals aren't really clear prior to this happening, it can be difficult. And very I don't know about traumatic, but can be very emotional for people becoming involved and trying to advocate for their loved one or to do what they think is right.
Yeah. Yes, I think that this has been a long held sort of conundrum really about when someone's admitted to aged care, and is that the time when you require an advanced care plan, or at least a goals of care form, or some kind of discussion around goals of care. I know where I worked, there was the idea that, they're already traumatized or they're already upset about coming into aged care. We don't want to hit them over the head with, and if you deteriorate and look like you're dying, sort of like that. It's all a bit too much. But I guess what you might be saying now is that what are the consequences of not having that conversation, at least when they're reasonably okay and they're in a better position to think with less emotion about considering the kind of situations they would want or not want to end up in, and to have that kind of approach standardized so that that everybody in the facility has some kind of advanced care plan and some kind of an idea about goals of care that's well documented, and even a process of regular updates, every couple of years, or when there's a change, that's what I'm always banging on about. If someone all of a sudden needs your services for some reason, there's a flag, there's an opportunity to come in and say, well, let's look at your goals of care and make sure they're still up to date and still matching with how you feel in the light of this new information, whatever that new information may be. So what kind of instances might they access your services for? So I know you do iron infusions. That's one thing that I'm sure you do.
Sure. So absolutely. So one of the things we will do is one of the simple things is when someone is going into care through hospital, and that might even just be as respite, we will follow them through hospital. Transfer periods are considered high risk. Things can go wrong. Communication can be good. It can be very poor. So it's making sure that everyone knows what's going on, and can be really important when transferring from hospital. So there are things that we're able to then follow up coming out of hospital that can make a difference. I think also, which I think is important, and I like to do as much as possible, is to visit a resident when they've come out of hospital and just say, hi, I'm coming from North East Health. I'm just checking to see you're all right. How are you doing? And I just think that sometimes a path through hospital can be very quick and bumpy and noisy, and you can feel a bit jostled. And just going in to check on people and for them to realise that they've not been forgotten and tossed out can make a big difference.
It must be great for the staff as well to have a point, because often the communication between acute staff and residential aged care staff And any time when you're transferring from one to the other, I remember those days when you'd get a phone call from a hospital saying, you know, you're accepting this patient. Yeah, okay. Oh, they give you a bit of a rundown. Oh, they're up and about and they're doing all the things for themselves. And then when they arrive in on the stretcher, you think, this is not the patient that I was expecting. You know,
No. Or
there's all
no
this stuff that they
paperwork.
don't mention because they don't want to. They want to sort of get this patient out of the bed as soon as possible, and so to do that they downplay a lot of the time, and so for them to be meeting someone like you must be great for the aged care staff to sort of have that link, that continuity, as well as for the resident.
Mm. And you mentioned iron infusions before. I mean, that's a lot of the things that we can do that, as I said, sit between it's acute care that sits between the GP and the residential care facility where they have no options. So we can come in and do an infusion that works really well with people, particularly with people with dementia, in that you're not upsetting them by transferring them out. We sit with them, we don't leave for them. So it can be a really beneficial way of providing a service. We also do investigations, and so we can we do wound assessments. We can also do lower leg vascular assessments, and this is a lot of it comes out of equipment that residential care facilities just don't have. Bladder scanning, ECGs. When you think about, I mean, for example, someone from Bright coming in for an ECG to Wangaratta, I mean, it's a huge undertaking for an older person to have to get in a car, if they can get in a car, and come in somewhere to get an investigation. It does make a big difference for us to be able to come out and do that.
Yeah. No, it's great. Yeah, I agree. I know sometimes, over your many years of nursing, we can, as junior nurses, we can often look at the more experienced ones and think, oh, you know, they're so much better, and oh, you know, they've got all this experience. But sometimes we think we can fall into the trap of thinking the experts are, have never made a mistake in their lives, but we know that's not true. Can you name a significant lesson from the past about getting it wrong, or one thing that you've really learnt about communication? You think, oh, that's a really big thing that I learnt, and I'll never do that again, or, you know, I'll change the way I do things because of it.
I can. There was one time where I was seeing a man with who was deteriorating hair. He had MND, and I was seeing him in tandem with his GP, and he'd been started on some fluids over a number of days, and some subcut fluids, and I needed to speak to the family. So there were 2 children, adult children and wife, about where they wanted to go with this. And because, I mean, that's something that just can go on and on and on. And the first mistake I made was not find somewhere to sit down and have a chat. So we were standing in the nurses' station, and part of it was I was unprepared, and I used clinical language, and I used the word goals. What are his goals? Which makes a lot of sense to me or to other nurses. But the family were really, particularly the children, were really affronted. It was shocking language for them, and they were offended. And so you then had someone who had their back up really quickly, and I'm trying to explain what it is that they want to happen. And we did eventually get to the point, I finally got to was able to speak to the wife and say, what is it that he wants? And she was able to say he doesn't want things to drag out. And it was at that point I was able to say, I think we need to stop the fluids. But that also is challenging for particularly adult children who don't live close by or haven't been part of the day-to-day decision making of someone who is deteriorating or dying. And so, yeah, that was, and I knew it at the time that I was really not making a good job of it.
Yeah.
I have since, I have done some study, and yeah, communication was a subject, and it was really, I learned probably a lot, the most in that particular subject, about how to approach difficult conversations, and how to get the best out of them.
Yes, yeah. And even interesting, you use the word difficult. I think even now we're starting to move away from like setting yourself up and saying, how do I approach a difficult conversation, rather than calling it difficult, say it could be challenging, and that means that there's an opportunity in there. It's not always going to be a hard thing. It just requires more of us, more attention and more skill, perhaps, and more sort of presence in those challenging conversations. And it's important to recognise when they are challenging. And I mean that fellow you talk about, that sort of speaks to the broader issue of if he was he was approaching end of life and he'd had MND for who knows how long, where had the communication fallen down all along that path, where to the point where the children weren't prepared, and that they were more in a position of sort of taking offence and being affronted, when you really were you had to sort of bring up those situations, and it fell on you rather than and it was like an immediate sort of big conversation that had to be had, instead of a series of smaller conversations that would have brought everybody up to the top of the hill where you were already. Yeah. And it's difficult for you as an outsider from you're not on staff as such, to just sort of swoop in, and then all of a sudden you're saying all this stuff that's really overwhelming. And I think that brings me to the point of something that I do always say too, is to not constantly fob off big conversations to the experts. Don't outsource, that's a palliative care issue, so I'm just going to refer that to palliative care. The people that work with these people every day, the aged care staff, they're the ones that the residents trust. They're used to them, they see them all the time, they've got a relationship with them. That is gold. To just sort of to palm them off when it comes time to have bigger conversations is really not fair on them. You're doing yourself a disservice, because I think you're much more capable than most aged care workers are, much more capable than they think, and much more able to have important conversations. It just takes a bit of time and a willingness to listen. Most of the time, that's really all it is. And then, and it's a natural conversation. Then, to sort of say, what is it that he wants? That's just such a simple thing to say. It's not shrouded in mystery, and you didn't go to study for 2 years to find out how to ask someone what they want.
That's right. Yeah, but I find often adult children who don't live locally can find a deterioration or end of life situation quite challenging, even if they kind of know what's going on. It's the exposure that you have day to day that helps you to see things, and it can actually you need to be aware and allow them some time. There was another time where I looked after a fellow, and he was quite clear with his end of life care plan that he didn't want anything extraordinary done, and he was deteriorating, I think, with most likely a respiratory infection, and family, and I'm sure we've all experienced this, swept in from Melbourne, and they wanted everything done. And it can be really hard to try and work out how to manage something like this. They were convinced that he could be treated in the facility, and we did end up together with the GP giving him some subcut fluids and some IV antibiotics. He didn't respond to treatment, but 24 hours can make a big difference in that family's experience. And I know some of the staff in that particular instance were a bit put out that we weren't following that goals of care to the letter. But I couldn't help but think that the impact that we were having on that resident was not great. But what it did for the family, though, was to allow them to have a positive experience of their parents' deterioration and death. And I still think back and on this particular instance and think about how they would have felt if we had have insisted on not providing any treatment or not taking what they wanted. You know, I would have had a bit more to say, perhaps, you know, if they wanted to go to hospital and have everything. But it made a difference, and I learnt a lot from that particular instance about how to read advanced care plans, or how to see things a little more broadly.
And I think the ideal would have been to bring as I always say, bring the family along for the whole ride, you know, and if there's one person who's interacting, but you know there's other people in the wings that aren't so involved, to try and make sure that they are on board and up to speed. But if they're not, then there is that real dance, isn't it, of allowing, as long as you're not doing, you know, great harm, allowing for the time for that person, and even just for their own mind now saying, well, we did try and then nothing happened, so we saw it for ourselves that it wasn't going to work, instead of walking away from the situation thinking they didn't even try antibiotics, you know, he might not have died, you know. And that carries, you know, the way people die lives on in the hearts and minds of those who love them
forever.
You know.
They will always have that memory of a bad experience with their parents' death. And to not, you know, well, they just weren't ready to come to grips. So now, even to see, you know, one family member say to the other who comes in for the first time, and when asked the question, are they treating it? Have we been trying it? And that person with only 24 hours saying, yes, we have been treating, but he's not responding. And so they feel like we've done what we can, and it really is his time. They don't have that question of, but what if?
That's really important, isn't it? Do you have a little tried and true tool that you carry with you, Deanne, around communication?
You're talking about an actual tool, or just something in my head?
In your head, you know, some little, you know, trick or.
Well, I think one of the things I've learned more recently is just to ask people how they feel first. So family and residents, ask them how they're feeling, what their thoughts are about what's going on. And so not only do you allow them to speak first, you actually get a lot of information on where they're sitting. And you're then able to structure what you've got in your head as to what you might need to say. Mostly people are prepared for what might be coming. But it's still always a shock, isn't it?
Yes. And it is, you know, I find that I think I had this conversation with Jackie today about being seen, feeling seen, and the importance for the person to feel like, rather than some doctor or, you know, some unknown person sweeps into the room and gives them all this information and then sweeps out again. Just the act of asking, you know, what's important to you, is that it's an enormous gift that you give someone, their ability to communicate to you who they are and what's important to them, because we can never know that unless we ask.
And I think giving good information and I remember one conversation I had I did an advanced care plan with a daughter and a husband of a woman who'd had a significant stroke and ended up with the peg tube for feeding. And we did talk about what they, all the usual things, advanced care planning, what they felt that she wanted, and how things were likely to be, and what were important to her. At the very end, I did say to them though, and this is around peg tubes particularly, at some stage you're going to have to decide that to pull that tube out or to stop feeding. It's because it's when someone's dying, they make that decision themselves, don't they? Normally, when they stop eating and drinking,
well, the body
and
does. Yeah,
absolutely. That's their choice. That's their consent. I've always thought, no matter how much dementia someone has, they still are able to tell you what their consent is around many things. But that's something that can just go on and on and on. And it wouldn't be an easy decision, and it didn't. I mean, for that particular lady, it didn't. She didn't. She lived for quite a long time after. But I just thought it was important for them to know that would be something required of them at some stage. Not easy. But I think things are important. I think it's important to pose a question and to let them mull. And like, as you said, people coming into residential care, I think it's important to say as they come in, at some stage in a few months, I'd really like to talk about what your goals are about dying and death and life and everything in between. And then let it sit for a few months, so that at least they've thought about things and it's not a shock when you pounce on them and make an appointment.
Yes. And the final question we ask everybody when we're interviewing people for this series is, what's the one thing you wish people knew about communication when it comes to aged care and palliative care? You got a final tip? Or
I think sometimes
parting
you got
words?
your mouth closed.
Keep your mouth closed.
Sometimes, well, not always, of course, not. But it's listen a lot.
Yeah.
I think with communication overall, listen as much as you can. Allow people to speak, even if they go off track, even if it's not necessarily what you're wanting to talk about. Sometimes just giving people time to express themselves about how they're feeling and what's going on can make a big difference.
Great. Thanks, Deanne. Lovely to chat to you.
Thank you for having me.
Yeah, and I think we'll finish off now. Thank you so much.
Oh, can I have one more parting gift?
Yes, please.
You're not going to always get it right. You're still going to make mistakes.
Absolutely, yes.
Or you're going to upset someone. It will happen.
So true. Thank you. Thanks, Deanne.